Good afternoon, everyone. I'm Janet Hughes. I'm a reporter from Gloucestershire Live, and we're here today, and it's the last of a series of 6 broadcasts where we're looking at the NHS's vision for the future in Gloucestershire. We've had a series of clinicians and managers from the hospital trust to talk through what their vision for the future is and the changes that they're thinking of making, the ideas they have to bring the NHS, make it as efficient as possible in Gloucestershire. And we're going to be talking to Cardiology. We've got Simon Lansley, who's the Director of Strategy at the hospitals, and we've got Rafe Chamberlain-Webber, Dr. Rafe Chamberlain-Webber, who's the consultant cardiologist, because we're about to talk about that department today. It'll come in 2 parts. You're welcome to ask questions. As the hospitals say, they're in listening mode. They want you to ask questions about their ideas. They want you to put forward what you think of them. So if you've got any questions, please do submit them and we'll put them, because it's not often you get a chance to question people like this. They're usually very, very busy people, and they've made time to come and answer your questions now. So please put your questions through. And I'm going to start with Simon, who's going to explain the model that they're using, which is a model of excellence, and it's Fit for the Future 2 now. We've already had Fit for the Future 1. This is Fit for the Future 2. And Simon, can you just explain a bit about what it is and why we're doing it?
Yeah, sure, Janet. So viewers may remember back in 2020, we came out and talked about a series of changes. There were 7 reconfigurations that we were interested in people's feedback on. So that was Fit for the Future Phase 1. Pleased to say that 5 of those 7 changes have been implemented, and Phase 2 is about the next stage. So there's 6 services in scope of Phase 2. And again, as you say, we're in listening mode to see what people think about some of these early ideas. But the strategy is the same. So people may remember from the earlier discussions, we talk about centres of excellence. So we wanted GRH to focus more on emergency care, and for Cheltenham General to focus more on planned care and oncology. Important to say that's not a purist strategy. So it's not necessarily all emergency care on one site and all planned care on another, and you see that with our ongoing commitment to maintain Cheltenham Accident Emergency Department. So important to say that that's not in scope here, and that service will remain as it has done since 2013, which is a consultant-led unit during the daytime and a specialist nurse unit overnight. So we use this language, centres of excellence, and we're not saying all 35 of our specialties are individual centres of excellence, but what the research shows, some of the best practice shows, is if you can co-locate some of your services on the same site. So typically those services that work together to rapidly stabilise, triage and diagnose patients. So things like trauma and paediatrics and acute medicine and cardiology that we're talking about today, and respiratory. Often these services work together in those early stages. They can use the same equipment and need rapid access to some of our diagnostic kit and equipment and some of our imaging equipment. So we're looking to co-locate those on the same site, and collectively that becomes a centre of excellence for emergency care. And then over at Cheltenham General, focusing more on planned care. So again, these are the specialties, the services that need reliable access to those facilities. So this is where patients typically have a date to come in. So a date to have a procedure or a test or theatre or surgery. And we need reliable access to those beds, theatres, day case operating facilities, critical care. Because if we don't have that, that's what ends up in patient cancellations, because you get that sort of that competition, if you like, between emergency care and planned care. So the strategy is the same. As I said, 5 of the 7 areas that we came to talk about in Phase 1 are now implemented. The 2 remaining ones is the acute medical take, and in some of what you'll hear from Rafe today around interventional cardiology, that's one of the ones we still need to do, and that's on track now for summer. Just a couple of other things about what Phase 2 is not about. So I mentioned Cheltenham A&E. It's not about the 7 specialties, that we talked about in Phase 1. So those ones are going ahead. And also, again, not clear to say, not a financially driven program. This is all about improving patient access, quality of services.
Okay. Thank you. Thank you for explaining that to us, Simon. And like you say, cardiology has had some changes already through Fit for Future 1. And now putting this together with Fit for the Future too. I'm going to come to Rafe now, and I don't want to make you blush, but we've had in a few nice comments from you and for you and your staff, so I think it's only fair to give them to you before we ask you a bit about this. We've got Lynn Roberts, who says it's the best cardiology department in my opinion, other than JR. She saw it at first hand and she's still attending. Such dedication, the whole team, and a massive thank you for all your hard work. So we'll start with Lynn saying something nice, because I think we've had quite a few comments in saying nice things. But can you tell us a bit about your department, why it's attracting comments like this? What is cardiology, and can you tell the difference between interventional and non-interventional cardiology? Because this is about non-interventional cardiology.
Yes, thank you. Just before I answer that, can I just thank Lynn for her kind comments? I mean, what we do is always a team effort, and there's no one individual that delivers the service. We rely on a considerable number of very talented and highly qualified colleagues to help us to deliver our service. So basically, cardiology is a specialty that deals with disorders of the heart and circulatory system, and covers a wide range of potential diseases which people may present with, including anything from abnormal heart rhythms, palpitations and things, to heart attacks, and sometimes valvular heart disease. So it's quite a technical speciality. We do rely on specialist equipment, particularly X-ray equipment, ultrasound equipment, to make diagnoses and treat patients. So a lot of our patients, when they come in, will require special tests or investigations. And that's what we refer to as interventional cardiology. We're actually doing things to people to get the diagnosis and make them better. There is a sort of another viewpoint, which there's a group of patients who may not necessarily need those particular tests, and they would be classed as non-interventional type patients. The only problem at the front door when people come in is that often you don't know which category they're going to fall into until you've seen them and assessed them. So those are two broad categories, and what we're dealing with today is the smaller category of patients who may not need specialist tests, i.e. non-interventional or medical cardiac patients.
And why would they not need those specialist tests? So that, what kind of conditions and how many people are we talking about? Or roughly?
So generally, as a proportion of the patients we deal with, it's a significantly smaller proportion. And the reason they may not need interventional tests is because they're already known to the service. They've already had the test done on a previous visit. And the reason for their admission may be related to other things, such as a need to change their medication, not necessarily further diagnostic or interventional tests. And that may occur in about 20–30% of patients, sometimes less, sometimes more.
Right. Yeah, that's very clear. Thank you. And can you tell us about where we are now with the non-interventional cardiology service, and what your plans are, or ideas are for the future? Your vision.
So at the moment we have we provide interventional cardiac services on both main hospital sites, at Gloucester and at Cheltenham. One particular type of interventional cardiology, which is delivered through the angiographic suite, where we do stents and pacemakers, is based at Cheltenham at this point in time. But we anticipate that will move to Gloucester Royal as part of a new image-guided interventional surgery hub. So we will share a space and facilities and staff with our interventional radiology colleagues, who do similar procedures, but outside the heart, in other areas of the body. So at the moment, the non-interventional patients we have exist on both sides of the county, but may have to move to the other site if they need their tests done there. So there is cross-site movement of patients, which is not always optimal in terms of efficient use of staff, getting patients investigated and treated as quickly as we would wish.
And so what is your vision to deal with that?
So ideally, from the clinical perspective, we would like to try and get all our inpatient beds, interventional and non-interventional, onto one site. And the reason that's important is because we can consolidate our health team, our cardiac team, who deliver the interventional and non-interventional services all together. It doesn't mean that we won't be providing inpatient cardiac services on the other side, because we will have regular clinics and consultant ward rounds as well. So patients will still get their inpatient cardiac review, but those who need interventional or more specialized treatment will be moved to the main unit at the other side.
And there'll still be clinics in Cheltenham and in the community?
Yes, there'll be no change to provision of the current outpatient service, both in Gloucester and in Cheltenham, and in quite a large number of community hospitals that we serve already. So those outpatient clinics, there's no plans to change those. And of course, as now, when we do clinics in community hospitals, we will often go and see patients on the wards there to consult and see if they need to have further specialist input.
As I understand it, we're talking about 8 beds, are we, from Cheltenham transferring over to, is that right?
Yes. Yes, that's right. So it's a slightly artificial figure, in so much as when a patient comes in, you don't know if they are non-interventional or interventional, because that may change during their inpatient stay or after their initial evaluation. But it gives you an idea that the proportion of patients we're talking about is relatively small. However, if we don't aim to move those beds, or we would like to move those beds so they join the main body of beds, then we end up with a split service, inpatient service, which doesn't achieve our fit for the future goal, really.
So the main benefits of these ideas that you have, what would be the potential benefits?
So the principal benefit is that we have all our specialist staff and equipment to deliver services on one site, and we have the patients that require those services and facilities co-located. It's difficult to explain how we struggle sometimes when we have staff crossing the sites between Gloucester and Cheltenham to do a test on a patient at one site and then go back later on the same day. That's potentially half an hour of dead time that they can't be working for the benefit of patients. So clearly having the specialist staff all together on the same site is a significant benefit for us, and means we get better use of their time.
And would it have benefits for the patient?
Certainly, because it means that we can provide more of these tests and assessments in one place, which means the patients get them quicker, their length of stay is reduced, their time to diagnosis is quicker, and their time spent in hospital is trimmed back to what is necessary and nothing more.
Okay. And all these things, they do tend to have a downside. Is there any downside to these ideas that you can think of?
So the only major drawback for this proposal is that patients who require inpatient cardiac treatment would have to travel slightly further to Gloucester Royal. So particularly that would apply to patients on the east of the county. But in all fairness, if they were admitted to Cheltenham and required specialist interventional care, they would still have to be transferred cross-county from Cheltenham to Gloucester, in the same way that a large number of patients are transferred from Gloucester to Cheltenham at the moment to access the cath labs, for example.
And will everything be on the site in Gloucester for you to be able to, is it like, I was going to say one touch, but it's a decision made first off instead of people being moved around a lot? Would it make that easier? Yeah.
Yes, that is. I mean, a lot of the emergency work we do is often time-based, and we have to try and deliver that within a certain minimum period to achieve the maximum benefit for the patients. So timing is always important for us, and that's why we don't really like to move patients around if it's not necessary, and also because sometimes they can be quite ill, and you don't want to be spending time in the back of an ambulance if you're ill. You want to be in the hospital getting the treatment you need.
Okay, and like you said, there'll be consultants at Cheltenham for general patients who may not be there for heart problems but may need a heart specialist for input. There'll be a consultant there for that.
Yes. So at any one time, you know, if you go into hospital, you don't just go in as a heart or a lung or whatever. You're a single human being, and we have to cater for all the potential issues that you may have during your admission. And so separating out specialities is a little artificial, but we will still provide inpatient cardiac review for patients. And so typically we know that our oncology colleagues often have patients who may require cardiac input. So there'll always be cardiac clinics running every day on the Cheltenham site. And in the same way as some other specialities, those consultants would then go on to see referrals on the wards and advise on further management of patients with cardiac conditions.
Okay, and that's a really good explanation. Is there anything else that I've missed that you'd like to tell people about?
I don't think so. I think I would emphasize the fact that as a speciality, we do cross quite a lot of healthcare professionals. So we have radiographers who help us to operate X-ray machines, to obtain images, to deliver our pacing. We have a large body of specialist nursing teams who either work in the catheter laboratories, where we do our interventional work, or on the cardiac care unit. And of course, we have a large body of physiologists, cardiac technicians, who we rely on extensively to provide specialist tests like heart recorders, sonar scanning of the heart, and devices like that. So it really is quite an integrated service in terms of the professionals we work with.
Okay, well, that's great. Thank you for explaining that and how it'll all come together. I'm just wondering if we can come to Simon now, because I'm sure the public will want to get involved in this. It's a very big, important service in Gloucestershire. Can you tell us sort of how the public can get involved?
Sure. Yeah, we're trying to we tried to use a wide mix of methods to get as many people to get involved and want to hear from as many people as possible. So you're right, this is the last one of these Facebook sessions, isn't it? We've done 6, but they're all available to watch again through the Glos Live Facebook or Glos Live internet site. The bus has been travelling around the county as well, and it's the last trip is tomorrow. It's on Southgate Street in Gloucester. So if viewers want to go down and talk to people face to face, it's there between 10 a.m. and 3 p.m. There's a website address that's running across the bottom of the screen, so people can find out more information there and get access to the survey. So that we've extended the survey now to the end of July, so we wanted to hear from more people. So, but if people can share feedback through that, and then again through that same website address, people can register for an engagement workshop. So the 6 specialty areas that we've been talking about, there's a face-to-face session from between the 5th and 12th of July, and the timetable is on that website. So people can register to make themselves available for that, which would be fantastic. Just a telephone number to drop in as well, if I may, Janet. So 0800 0151 548. So if any viewers would like a copy of the book in larger print or in Braille, or to access in another language, they can leave a message at that with their address, and we'll get that posted out to them.
Okay, that's great. And can you tell us what happens next and a bit of the timeline?
Yeah, so as I say, extended the survey element to the end of July. We then pull all that together in something called an output of engagement report, which sounds very technical, doesn't it? But effectively, that's all just the key themes and messages that we've heard from people over the last month or so. And we play that together with the ideas that we've been suggesting to see, do we need to tweak anything? Do we need to do anything differently? Or do we need to go back out and clarify any of the changes? And depending what feedback we have from that, from this session, will determine where we go next, whether we need to do some further consultation or whether we can go into implementation phase.
Okay, well, thank you very much. But we've got 1 or 2 questions here. First of all, I'd like to say to Rafe Chamberlain-Webber, I've got another lady, Susan Davis, wants to say thank you. She said, you looked after me in the middle of the pandemic. Lovely people on the cardiac ward in Cheltenham, still haven't forgotten their kindness. And then we've got another one. Lucy Norton's asking, how long after a GP referral to cardiology does it take to get an appointment? I think waiting times is a big issue for people at the moment with cardiology, isn't it? So I'm just wondering if you could answer that, really.
So yes, I mean, although it's not directly related to the movement of beds across county, it's not ideal at the moment, and there's a variety of reasons for that. The principal one, of course, is that heart disease didn't go away during the pandemic when we reduced a lot of our outpatient work. And unfortunately, and as is the case in a lot of other specialities, there was a large accumulation of work, outpatient work to be done and patients to be seen. And we are still working through that backlog. And obviously, as referrals continue, that means that some patients will have to wait a bit longer, unfortunately. We do clearly try to prioritize or triage patients so that we see the most urgent as quickly as we can. And it's just one of those unpleasant parts of the job where you have to decide who's more urgent than someone else and who can wait a bit longer. There's no easy way around that, I'm afraid. One advantage of the proposed moves, of course, is improved efficiency of our service, even without expanding the beds. And that is good because it means that we can treat more people more effectively and quicker. But those changes obviously will take some time to feed down through the system.
So if I'm right in saying this, there'll be less time travelling between the two sites, so there'll be more time for staff to work their way through those waiting lists. And as far as Lucy's question is concerned, there's no set time. It depends. There's a judgment call to be made.
Yeah, there's no set time. It's like a piece of string, really. I mean, the GPs who refer patients to us give us the necessary information, and we have to sort of weigh that up in terms of urgency. And if patients have been seen before or require the test, we will try and do this before they're seen. But it is a question of prioritizing, I'm afraid, and we would like to see everyone as quickly as we can, obviously, but inevitably some people are more urgent than others.
Okay, I hope that answers it for you, Lucy. So we're going to say goodbye now. This is the end of our 6 broadcasts about the changes, and you need to have your say because these ideas are being put forward now, and it's up to the public to say what they think about them. And I'm just going to look aside and I'm going to read them to you now. These are the areas where the NHS want you to have your say. If you've got anything to say on the proposed ideas for these new areas, please get in touch, take part in the engagement exercise. So we've got benign, non-cancerous gynecology, diabetes and endocrinology, frailty and care of the elderly, non-interventional cardiology, respiratory and stroke. If you're involved in any of those 6 areas, please get in touch with the hospitals trusts, send in your ideas, send in what you think of theirs, and hopefully they will listen because you've had an opportunity to have your questions answered now. So thank you for Dr. Rafe Chamberlain-Webber for giving us some time today. And thank you, Simon, for giving us time for the last 6 broadcasts we've done. And hopefully people will take part and tell you what they think of your ideas. And I'm sure everybody would like to say thank you for all you've done for us all through the pandemic as well. So thank you, everybody. And we'll see you again. The numbers, everything's there for you under the screen, how to get involved. And hopefully you will. Goodbye. Thank you.